Good morning, everyone. I think we probably have a few more people that'll keep joining us this morning, but we have a full 90 minutes today with you. So I want to make sure that we respect everybody's time and we can get started right away at 10 o'clock. So first of all, thank you so much for joining us and welcome to the Wisconsin Cancer Collaborative webinar, Helping Cancer Survivors Thrive, a look at equity data and culturally responsive survivorship care. So we are so pleased to have all of you with us today. Just a couple of things. First, I'll introduce myself. I realize I'm Beth Brenner. I'm the director of the Wisconsin Cancer Collaborative. So I really thank you for joining us. Lots of our staff team are on here today. So hopefully there's lots of friendly faces and familiar names. And we're all here to help you if you have any questions or need anything throughout the day. Today's webinar will be recorded and we're going to share the slides and the recording later on this month. I just also wanted to let you know that closed captioning would be an option. So if you wanted to use that feature, it is available down in the lower right-hand kind of portion of your screen. And also, we're going to keep everybody muted this morning, but I want people to please enter in comments and questions into the chat so we can have a really active chat as these presentations are happening throughout the day. I wanted to start off this morning and before we welcome our guest presenters with a land acknowledgement. So the Wisconsin Cancer Collaborative, as we sit on the UW campus in Madison, acknowledges that we occupy the sacred stolen territory of the Ho-Chunk people on the land known as Dijope since time immemorial. We honor the inherent sovereignty of the Ho-Chunk Nation and all 12 tribal nations that reside within the boundaries of present-day Wisconsin. So wanted to make sure we acknowledge all of those on the screen, both through the map and through the written words. A long history of harm against the Native people and their homelands has created health inequities that persist today. As healthcare professionals, we recognize our responsibility to work in solidarity with Indigenous communities to dismantle these inequities and support healing. We use this acknowledgement to urge thoughtful action that can restore the health and well-being of the land and its people. We encourage our members to learn about the people whose ancestral homelands you occupy, to stand with Indigenous communities, and to lift up Indigenous voices in ways that are grounded in respect, integrity, and reconciliation. So I know that was me reading a little bit, but I also want to just make sure you know that it comes from the heart of me and our team and our presenters today. And we just wanted to really make sure that we really led with that important sentiment as we start today. So what is today going to look like? We're really so excited that we can have two of our member organizations join us as presenters today. So as you see us walking through the day, we're going to talk about the latest state cancer survival data. So I'm really excited. This is what I suppose you could say hot off the presses. So this is going to be great information we can share with you. We're going to talk about our strengths and our gaps in survivorship care in Wisconsin. So that's kind of an ongoing project that we've been working with our partners at the collaborative. And then the importance of providing culturally responsive survivorship programming for Indigenous survivors and caregivers. So I'm so grateful to have amazing partners that were able to join us today and share with us the work that they're doing. And then we're going to conclude with facilitated breakout sessions. So we hope you stick around or participate in those. And I will tell you, that is just going to be a time for us to share. So as we kind of sit in our own spaces and are always looking for that opportunity to connect and just talk, that's what that's going to be. So I really encourage you to stay and be a part of those breakout sessions. And again, if you have any questions, keep that chat going because we would love to just see an engaged conversation outside of that too. So objectives for today. First, June is Cancer Survivor Month. So we want to make sure that we are celebrating survivors, but we also want to make sure we're learning and we're improving how to support survivors across our state. So as you can see, we want to discuss the new data in Wisconsin through the Wisconsin Relative Cancer Survival Report. I'll get it right soon, Haley. I will, I promise. Lots of words. And what that's going to tell us about the trends and where we can go. We're also going to discuss other Wisconsin data. A lot of these are some things you've seen before and some of it's new information. So I'm really excited we can have Alexandria share that with us today. And then we really want people walking away with our survivorship partner and what the American Indian Cancer Foundation is doing to support survivors and caregivers. So before we get started, I want to just briefly mention about the Wisconsin Cancer Collaborative for those that may be new to us and to our webinars. So we are the State Comprehensive Cancer Control Program and the Statewide Cancer Coalition. We have approximately 140 plus organizations that are working together to reduce the burden of cancer. So our members are here to connect and provide tools and support and knowledge. And it's really grounded around our state cancer plan. So it's a way for all of us to begin and working on reducing the burden of cancer in Wisconsin. I would encourage all of you to join us. Membership is free, and it's really just not only so you can connect, but you can see those resources and tools that we share on an ongoing basis. And I think we're going to just put the link in the chat. So otherwise, it's just wicancer.org. So please, if you haven't been on our website before, please join us at any time. So real quick, putting the plan into action. So we have a 10-year cancer plan, the Wisconsin Cancer Plan 2020-2030, and we wanted to just call out a few areas where today's webinar is going to really highlight the work in that plan. So you can see we have chapters. We have 7 chapters throughout the plan, and this webinar is really going to speak to 3 of those. It's going to speak to our health equity, our cancer survivorship, and our cancer data. So I'm really excited when we can talk through opportunities that really cover multiple areas of the plan, because we're really just working then to reduce that cancer burden for everybody. So I am so excited to have our first speaker join us, because part of it is we're going to announce the new report, the Wisconsin Relative Cancer Survival Report, and it's soon to be released information. So this report is really going to set the stage and help us know what cancer survival rates look like in Wisconsin. And this report can help people inform prognosis, evaluate, compare treatment options, look at trends, where are opportunities for improvement and prevention, screening, early detection for all different types of cancer. So I am honored to introduce our partner, Haley Tymeson. Haley is an epidemiologist with the Cancer Reporting System at the Wisconsin Department of Health Services. So Haley, I'm going to turn it over to you.
Thanks, Beth. I'm Haley Tymeson, like Beth said, and I'll be talking through some of the findings of our relative survival report. So let's just jump in. First, let's just define what a relative survival ratio actually is. As the slide says, relative survival is a measure of excess mortality experienced by people with cancer. And the way we calculate this is by looking at observed survival among a set of cancer patients and comparing it to expected survival. And observed survival here is defined as the percentage of a population of cancer patients who are still alive 5 years after receiving their diagnosis. And we set the expected survival as the percentage of the general population who is still alive 5 years after a similar 5-year period. So this is just to kind of put it into context of what cancer patient survival is versus what it might be expected to be if they hadn't gotten cancer. So on the next slide, we'll walk through a couple examples. First, let's just calculate a 5-year relative survival ratio for patients diagnosed with lung and bronchus cancer between ages 15 to 44. We see here that observed survival, again, our percentage of lung cancer patients diagnosed ages 15 to 44 who are still alive 5 years after diagnosis, is about 38.2%. And then when we compare that with expected survival is a lot higher. And that's kind of to be expected because it's the percentage of the general population, also ages 15 to 44, who are surviving a similar 5-year period, and that's around 99%. So we simply divide observed over expected, and we get relative survival of 38.6%. And the way you can understand that is these lung and bronchus cancer patients ages 15 to 44 are about 38.6% as likely as the general population to survive 5 years after diagnosis. On the next slide, we'll do the same thing, but for patients diagnosed at ages 75 plus, just to see how much the expected population comparison can change things. We see that our observed survival has fallen to about 13.5%. So those lung cancer patients ages 75 plus, about 13.5% are still alive 5 years after diagnosis. But we also see that expected survival has fallen a lot, down to about 70%. And this makes sense because people ages 75 and up are facing a lot more competing causes of mortality. And we would expect more of them to pass through background mortality. So when we divide observed by expected this time, we see a much bigger difference between our observed survival and relative survival, because we're kind of taking into account that background mortality that those cancer patients would face, even if they hadn't been diagnosed with cancer. And we get relative survival close to 20%. So that's roughly what relative survival ratios are. I'll talk through the methods of the report really briefly. We use the actuarial method, which involves life tables. And to make sure that those observed and expected populations are a close match, that the expected group is really a good counterfactual of what might have happened if those patients hadn't been diagnosed with cancer. We match by age, sex, socioeconomic status, geography, and race. Second, all the estimates I'm going through here are age standardized, except for any age-specific relative survival ratios. Next major point, oh, sorry, can you stay on this one? We're looking at diagnoses made between 2011 through 2017, and then we'll follow those patients for as long as possible. And if they hadn't died by our study cutoff date of December 31st, 2018, we'd presume them alive. You'll notice for patients diagnosed in 2017, we couldn't follow them the whole 5 years, but including that, those data points, even though it's not the full 5 years, still lend some stability to estimates. So when we look at relative survival here, 5-year relative survival, a lot of that is coming from the earliest diagnoses, 2011 through 2013, that we can follow the full 5 years. So we should kind of interpret these with caution. These are not the fate of patients diagnosed with cancer now. It's been over 10 years since the first diagnoses included, and a lot has changed. So we don't want to take these as what will happen to cancer patients. We'll be looking at some relative survival information by cancer site, by stage at diagnosis, age at diagnosis, and by race. And one last methodological note on race. We only estimated relative survival for white, African American, and American Indian populations, and intentionally did not estimate for Asian and Hispanic populations due to methodological limitations. Okay, so the cautious good news is since the last time we estimated relative survival in Wisconsin, back in 2016, using 2005 through 2011 data, cancer relative survival in Wisconsin has increased by about 2.6 percentage points. It's worth noting there's a lot of things that can affect survival, and this doesn't necessarily mean improvements in treatment or access, but it is cautiously good news. So first, we'll take a look at relative survival in Wisconsin compared to the United States as a whole. It is generally similar for all cancers. Wisconsin has slightly higher relative survival for all cancers than the United States as a whole. When we look by site, there are a few cancer sites where Wisconsin has slightly lower relative survival. Those are marked with the arrows and are prostate, thyroid, melanoma, and brain cancers. But there are also sites where relative survival is higher in Wisconsin than the United States. The ones that jump out are leukemia, myeloma, bladder cancer. And the other thing you'll notice from this plot is how different relative survival is by cancer site. Cancers like prostate and breast cancer can have pretty high relative survival, whereas pancreatic and brain cancer much lower. Okay, so here we're plotting relative survival ratios by stage at diagnosis. And for those who aren't familiar with stage, it's kind of a measure of how far the cancer has spread when you're diagnosed. So at the local stage, it's still in the organ it originated. The regional stage is spread to adjacent organs or nearby lymph nodes. And at the distant stage, it's spread to distant sites of the body. And we generally see highest relative survival when diagnosed at the local stage, going down as you go towards the distant stage. These patterns can vary though. For example, prostate cancers diagnosed at the localized stage have really high relative survival, almost as likely as the general population to live 5 years after diagnosis. Whereas lung cancer, local diagnoses, relative survival is much lower at around 60%. And these patterns differ by site as well. When we look by age, if you look at the all cancer section of this plot, we generally see falling relative survival as age increases. But again, this varies a lot by site. If you look at breast cancer specifically, relative survival is pretty steady across all of those age groups, whereas colorectal and lung cancer show a little bit more of that age pattern. And last, before we show some race and relative survival metrics, I wanted to talk through some of the ways race can be associated with relative survival, because there's a lot of different places in a cancer journey it can come into context. So race through associations with genetics can predispose certain people to a more aggressive type of cancer that's more likely to lead to mortality. Race can be associated with factors that make access to preventative care like vaccinations and screening more or less difficult. And the same goes for access and quality of care. So there's lots of different ways for race to be associated with relative survival. These are kind of a starting point to see what the disparities are. And from there, we can figure out maybe what mechanisms are at work and where we can intervene. So when we look at 5-year relative survival by race for all cancers and major cancers, we generally see that white populations have the highest relative survival. Then slightly lower for African American populations and lowest for American Indian populations. And this tended to play out for most of the cancer sites we looked at in the report. There are some exceptions. For example, prostate cancer, African Americans have slightly higher relative survival. But again, we just see this as a starting point to look at what are the disparities, how can we start to intervene. Okay, and usually when I hit these slides, I'm roughly out of time. So we have some tables on relative survival for different types of cancer. You can also definitely check out the report if you're really interested in this kind of stuff. There will be much more time to sit with the methods and the results. If you're interested, we have additional cancers that we talk about in depth in the report as well. And I'd be happy to take any questions if I have any time left.
Thank you, Haley. We definitely have a minute if there's any questions. I don't see anything currently. I'll give it just a few more seconds to see if anybody had. And one thing I will mention, if you are so fascinated by this information and saying, I want to know more, you get to know more soon. We are in the final stages of approving the report to go live. So you will be able to see Haley's report very shortly, hopefully in the next week or two. This whole report will be released. Haley, there was a question that came in about any information regarding rural disparities, if there was anything in this report.
No, we did not look at urban rural disparities in this report specifically. I do know there's a lot of literature out there, but not specifically in this report.
Thank you.
Okay, I think we can transition to me now then. So hi everybody, my name is Alexandra Culweather and I'm an outreach specialist with the Wisconsin Cancer Collaborative. And I'm currently on Kickapoo, Peoria, Sauk and Meskwaki, Miami, Ho-Chunk and Siouxland. And thank you to Haley for providing an excellent summary of relative survival in Wisconsin. I hope everybody gets a chance to read the report once it's published. And overall, it's really great news to see what more and more people that people with cancer are surviving their diagnosis and treatment. However, we must now ask ourselves whether our cancer survivors are truly able to thrive as they transition away from cancer diagnosis and treatment and navigate their lives. And so the second half of our discussion today will really help us dig into this question. And just as a fair warning, I'm going to be also throwing a lot of data at you, but I promise it's important. And so I want to start with a definition to set the stage, since we were just talking about survival and now we're talking about survivorship. And so according to the National Cancer Institute, an individual is considered a cancer survivor from the time of diagnosis through the balance of their life. And survivors include people with a current diagnosis and people now free from cancer. And caregivers, family members, and friends are an important part of the survivor experience as well. And so cancer survivorship refers to the health and life of a person with cancer post-treatment until the end of life. And so really this is everything from the physical, mental, emotional, social, and financial effects of cancer. So it's really a lot all encompassed into one. And so as we know, cancer survivors have unique needs. And as the number of cancer survivors grow, we need to establish approaches to addressing these needs. Also, we know that people are addressing this across the state, but we wanted to know where we are at. So the first project I'm going to be talking about is the 2020 Wisconsin Survivorship Care Survey we conducted. And so this project surveyed cancer treatment facilities in Wisconsin. With the help of our CDC-funded Cancer Survivorship Supplement, we set out to complete a statewide environmental scan of survivorship to assess what's going on, share key survey findings and opportunities for improvement, connect those who work on survivorship with their peers, compile and share resources, and establish a community of practice to improve survivorship programs in the state. And so I'm going to be highlighting a few of the key findings, but the overall results had a lot more detail. And our key findings were published in the Journal of Cancer Survivorship in October. We also provided each participating site with a snapshot for their own internal use prior to publication. And so this compared their site's answers to the aggregate. And this is a great way for sites to show to their coworkers and their leadership how they compare to others. For example, one site was able to use this data to justify the need for hiring another patient navigator, which was really, really great. And we really try to have a representative sample participate and to capture the variability of survivorship services in Wisconsin. We wanted to make sure we had both urban and rural, multiple health systems, the main sites and the smaller outreach sites. And some of these sites were still in the early stages of building survivorship work, and some are well established. I also just want to give a huge shout out to survey sites that have participated, as many were struggling with competing priorities, especially with COVID. And despite all this, we had 40 sites represented in the survey, which I'm so impressed by, and I'm thankful for the hard work of this group, and I want to acknowledge that. And so we use something called Rural Urban Continuum Codes, or RUC, to classify cancer treatment facilities and centers by how rural they were. And so 32 sites were in RUC 1 to 3, so urban, and 8 sites in RUC 4 to 9, so more rural. And as you can see, most sites clustered in 2 metropolitan areas, which wasn't surprising to us. And 18 sites were COC accredited. And so the good news is that over 80% had these services available to survivors, including educational material, financial counseling, spiritual support services, and survivorship care plan discussion. And here you can see this is based on number of survey site responses. Green means it was commonly available, yellow means sometimes, and red means least frequently offered. And for another strength, some common standards of care include discussion of need for regular follow-up and screening post-treatment, because that's a really important part of care, providing patients a written treatment summary, and often providing the primary care provider the plan as well. And many sites were discussing late and long-term effects such as emotional distress and fatigue with all or almost all patients. And then I want to take a second to focus on the gaps that we found in the next few slides. And so one major area was discussing needs for emotional and social support was most often a standard of care. However, a referral to a specialist for mental or behavioral health concerns was not. In fact, psychology services were only included at about 67.5% of sites, and this service received the largest spread of responses. Perhaps this reflects that all survivors are not meeting the criteria to be referred to a specialist for mental health concerns. However, perhaps this also highlights an area of improvement, as we know that mental health is an important part of the survivorship experience, and as many as 3 out of every 4 cancer survivors experiences distress, and studies suggest that less than a third talk to their doctor about these concerns. We also found that risk reduction services, dietary services, access to physical activity were described as standards of care in less than half of sites. Additionally, when they're offered, they're provided upon request only or if risk stratification criteria was met. And exercise and physical activity services are most often referred outside of the health system entirely, so to places like the Livestrong at the YMCA program. And this is interesting to me because rehabilitation and exercise interventions can really help improve cancer survivors' quality of life and survival by reducing the negative impact of long-term effects such as fatigue and lymphedema. And they're also important for risk reduction for subsequent cancers and other health issues. Also, guidelines commonly recognize and recommend rehabilitation as beneficial, but use of these services, referral to these services, and integration into oncologic care is really low. Another gap area appears to be sexual health and/or fertility services. For example, reproductive endocrinology was included at only about a third of follow-up care teams, as were fertility specialist services. Sexual health services were offered at 55% of sites, and sexual functioning was the only late-term effect with any responses for rarely or never discussed, indicating a possible gap area. So just to illustrate another example of this, most sites that serve adolescent and young adult survivors in the survey did not have a reproductive endocrinologist on the care team. About half of the sites that served these younger survivors offered fertility services or fertility specialists. So this reinforces our discussion, indicating that fertility and reproductive issues may be a concern, but it can be difficult to talk about. And without these services, we don't know the demand or the delivery. We can't measure that or provide that. And so a common theme in conversation we had about these services is they may be offered less due to variable insurance coverage. Reimbursement for many important survivorship services, such as behavioral interventions, is not currently available. Policy solutions should be explored to increase insurance coverage and provision rates of necessary survivorship services to keep up with projected increase in demand. A possible example of this is many fertility treatments are not considered medically necessary by insurance companies, and so they're not covered. And only 15 states currently require some private insurers to cover some fertility treatments. And Wisconsin does not require insurers to cover fertility treatments. Also, this survey highlights areas we need to address and improve upon. And I would be remiss to not mention some of the limitations. COVID-19 definitely hampered participation for many. Not every site in Wisconsin was surveyed, and many of these were more rural. Not every site responded. This was self-report from health care provider teams at each site, and this is not from the survivor perspective. So it'd be helpful to know what would be beneficial for survivors' needs and what services they find helpful. And so just really some of the next steps from this project, we're continuing to share relevant cancer survivorship resources and opportunities to members. We're amplifying work that our members are doing to improve survivorship care. So if you have something you're proud of or a resource you created, we love to hear about it. We love to share that work, so please feel free to reach out. We're working to expand the community of practice to improve survivorship programs in the state, exploring policy and systems change, and identifying key priorities and strategies to implement change. Additionally, we have some reports on actual Wisconsin cancer survivor perspectives from 2 surveys called the Behavioral Risk Factor Surveillance System, BRFIS, and the Survey of the Health of Wisconsin, also called SHOW. And really, these provide a snapshot of limited patient perspectives, mainly white, older, higher socioeconomic status respondents. So they don't reflect the experience of every Wisconsin survivor, but they provide some insight. And I'm not going to go into a lot of detail. I know I'm running low on time, but if you're interested in learning more, we will have these reports on our website. And so I'm going to skip over BRFIS right now and just highlight a few things about SHOW. And so SHOW stands for the Survey of the Health of Wisconsin. This is a population-based health study of Wisconsin. So people who had a previous diagnosis of cancer were sent a cancer survivorship survey in the mail in 2019. And some good news is that a large majority felt their worries were being addressed by their treatment staff. They reported satisfaction with how things were being explained to them. They felt they could discuss any concerns. But on the other hand, sexual health and emotional distress were 2 examples of topics some survivors did not feel they could discuss with their provider. And 27% of respondents reported never having discussions with their provider about late and long-term effects. And I find this really interesting because there's also gaps in the survey of health systems that we did. And just the financial effects of cancer diagnosis and treatment were also analyzed. And so there's greater financial burden among younger and female survivors, African American survivors, survivors with less than a high school diploma, and survivors with cancer such as lung and ovarian. And so reducing cancer costs is a key strategy in our cancer plan. And we just wanted to put a plug in for our financial toxicity of cancer issue brief. And then just one final bit with this is we also looked at alcohol use during chemotherapy. 30% of people in the study reported drinking alcohol during chemo. Alcohol use during chemo was higher among older adults, men, smokers, and those with non-alcoholic related cancers. And more research is really needed to identify the risks and benefits of alcohol intake during cancer treatment. Also, clinicians should address the impact of alcohol use after cancer diagnosis, especially during cancer treatment. And so our key findings about alcohol use during chemo are going to be published in the Wisconsin Medical Journal shortly, and a more general SHOW report findings will be a future report found on our website. So I invite you to read that when that's available. And again, I think it's really great we have Wisconsin-specific data, but I want to acknowledge that the diverse experiences of cancer survivors are not necessarily represented in this data. To make sure we're capturing different experiences and that our work is relevant to the communities of greatest need, groups that are underrepresented in prior data need to be included and prioritized, and work needs to be done to dismantle the factors that may contribute to distrust or influence a person's decision to take part in a survey like these. Additionally, mental health and sexual health services are often underutilized in cancer survivorship, and many survivors feel discomfort about talking about these topics. So we really need to work on reducing stigma regarding these issues, increase access to these services. And so I'm going to skip questions for now, and I'll take some at the end. And we're going to pivot a little bit, and I'm going to welcome a Wisconsin Cancer Collaborative member organization and partner, the American Indian Cancer Foundation. We've invited them here today to share with us their wealth of resources, services, and expertise they have in serving as a national nonprofit focused on addressing cancer inequities faced by Native communities. Their mission is to eliminate the cancer burdens of Indigenous people through improved access to prevention, early detection, treatment, and survivor support. And so I'm honored to pass it on to our guest speakers, Lindsay Petras and Michelle LaPlante, to speak about their cancer survivorship programming. So thank you.
Thank you very much, Alexandra. Bonjour, Anine. I'm Lindsay Petras. I'm the Cancer Program Manager, and I am excited to talk to you all today about reclaiming Indigenous health by centering kinship with cancer survivorship programming. Next slide. So who are we? Who is the American Indian Cancer Foundation? We're a national nonprofit organized to establish and address tremendous cancer inequities faced by American Indian and Alaska Natives. Our mission, like Alexandra said, is to eliminate burdens on American Indian and Alaska Natives people through education, improve access to prevention, early detection, treatment, and survivor support. So what is our approach? We believe Native communities have the wisdom to find the solutions to cancer inequities, but are often seeking organizational capacity, expert input, and resources to do this work. We support innovative community-based interventions that engage Native people in the discovery of their own cancer best practices. We strive to be a partner trusted by tribal and urban communities, leaders, healthcare providers, and others working toward an effective and sustainable cancer solution. So again, we're going to talk a little bit about relations. I'm Lindsay Petrus. I am the Cancer Program Manager, and I'm located in Wisconsin on the homelands of the Bad River Band of Lake Superior Chippewa Indians. And I can pass it over to Misha quickly.
Bonjour everyone. Hello, my name is Misha LaPlante. I'm the Cancer Programs Project Manager. I am a Bay Mills Ojibwe Indian community member as well as a Blackfeet Nation descendant, and I am located in Minnesota on Dakota land.
We would love if you would be able to share your name, what your role is, and who stewards the land you're on, and what do you dedicate your work to? We'd love for you to share that in the chat right now. Next slide, please. So our learning objectives. By the end of the presentation, we hope that attendees will be able to define kinship in relation to public health programming and services, specifically cancer survivorship programming, understand the ways to reclaim and revitalize Indigenous health and sovereignty by centering kinship, and strategize several ways to support cancer survivors in leading the movement to reclaim Indigenous health.
So like the Wisconsin Cancer Collaborative, we have a very similar cancer survivorship definition. So for us, cancer survivorship begins at diagnosis and lasts throughout one's lifespan. Survivors can be community members, caregivers, and or other loved ones who are intimately impacted by a cancer diagnosis, such as a child, other dependents, or other relatives who are really close to the cancer patient who is in current treatment or in remission.
So some of the things that AICAF does. So some of the things we do is health systems partnership. So we really try to champion intertribal collaboration to define cancer barriers and solutions in and across Native communities. So we really try to work with Native communities to understand what those needs are and how we can overcome barriers. We assist health systems to identify gaps and find solutions to effective cancer prevention and care. So what are those solutions? What are those different things that a specific organization or community need to really enhance those services for their community members? We offer system support to improve cancer screenings and tracking systems. So sometimes it's simple as getting some of our partners to connect with their electronic health record vendor, connect with IHS to really identify how to use maybe that iCare system to send out reminders to their patients for those preventative screenings. We conduct healthcare provider education to increase awareness of the importance of provider role in recommending the right screening, referrals, and treatment for every Native patient. So really finding out what those needs are at the health system, what those providers need to really connect with their patients. So having those conversations. Some of the other things we do is we do community education and outreach. So we perform education in the community. We try to attend different events in communities to promote some of that cancer prevention, early detection, and encourage positive health behaviors that can aid in the healing of families. Really looking at the community health workers as that the key to success. They are out in the community, so really trying to uplift community health workers in the work that they're doing and reaching out to those different individuals that might not have those resources. So really providing that education. So really trying to uplift any of those health workers to overcome some of those screening barriers. Maybe it's a ride that they need to get to the clinic, to have their stool test, to grab their stool test, whatever it might be. Some of the other things that AICAF does is community-based research. We work with individuals' communities to identify research questions, methods, and funding opportunities, support the collection and use of population-specific data and guide efforts, make sure our findings are shared and published so all Native communities can benefit from new health ideas, knowledge, and methods. So AICAF really prioritizes our relatives, tribal communities and sovereignty and self-determination, Indigenous lifeways and knowing. So really we try to prioritize that in those conversations in collaborating with any organization or community. Those are very important to AICAF. We trust, having that trust in the community that they have the wisdom and solutions to address any health disparities that they might have in their community, and really leaning into their knowledge. They know their community intimately. We're there to support and uplift the work that they're doing. Really ensuring that we're including the community when we're having these conversations early on, including the community in those conversations. What are those needs? What are the different things you can be doing to really uplift that work? Find the barriers, try to, resolve those barriers. Change organizational practices. What needs to change in the organization to really make that difference? Move that needle. And having actualized change happen through strategies, that you discuss with the community, and making sure that those engagement opportunities are happening and those conversations are happening, because if you don't have buy-in from the community, you're not going to move that needle. And so really having that conversation early on, that that's an important thing that we should be doing and that we need to do in working with the community. So this is just a graphic, a visualization in our cancer burden booklet. We are working on updating our booklet currently, but as you can see, for Native people, cancer is the #1 cause of death for women and the #2 cause of death for men. So this is just a good visualization to kind of show you that. So as you can see, this is a map of the US. This kind of gives the 6 different geographic regions that IHS kind of parses out. And so you'll notice that, there's going to be distinct patterns and differences in each of these regions on different cancers. And so, just kind of giving you that visualization that this is how IHS kind of identifies each region.
Sorry, just typing a little note, greeting to all of you. So I'm going to talk a little bit about our survivorship survey. So these are the results collected in 2022 so far. I'm not going to go through previous years, partly just because we might have a little bit less data and feel that this was a little bit more comprehensive. So overall, the Native relatives who had filled out this survey reported that they were diagnosed when they were over 50 years old. I am not sure. Oh, there's representation from all across the country, predominantly in the Midwest, particularly because that's where a lot of the work that AICAF does is situated right now, but we are a national organization. Most responded as cancer survivors who were in remission. Most were female respondents. Many of our relatives, unfortunately, were diagnosed in stage 4 with a range between 0 through 3. And nearly half lived in rural areas, with the other half in urban settings. So this is a graph about what kind of information our relatives are seeking. So this includes, so right now we can see that some of the things that they really want to learn more about is understanding your cancer care. So for example, treatment options, navigating, probably clinical trials, as well as taking a look at side effects and other things like that. They're also really interested in getting information about work, financial, and legal examples. So for For example, applying for insurance, assistance programs, particularly for maybe transportation or other financial opportunities. So these next two slides kind of go together. So how we asked, how has COVID-19 impacted your traditional medicine cancer treatment? And so overall with both of these slides, actually, you'll see that COVID-19 has not affected their care. And so we were really grateful to see that. You can actually skip the next few slides. Yep. Yes, and so this is asking about non-traditional commercialized medicine cancer treatment. So kind of reframing away from like using Western medicine as a situation or as a point of situation, and looking at it as more non-traditional versus commercialized or academicized. So some of the biggest takeaways were that there are many barriers to quality care. So some of it being finances, transportation, and then having a culturally responsive healthcare team. Other big challenges that were listed include treatment and side effects, as well as dealing with the day-to-day feelings. Many reported that more support was needed around those barriers to care, particularly again, around, again, finances, transportation, and culturally responsive healthcare, clinical trials, social emotional support, and then that financial support. Again, I think it's just really important to highlight. So I wanted to make sure that you all know that Native cancer survivors can participate in this survey throughout 2022, and the survey will close on December 30th of this year, and there is a link provided in the PowerPoint. So yeah, we're going to be talking a little bit more about now revitalizing Indigenous health and sovereignty by centering kinship. So one of the main questions that I ask, or that our team asks, as well as all of AICAF, is just how do we support the patient, relative, and community member to make decisions on their health that best reflect the person, relative, ancestor they are and they want to be. So we know that one of the ways to encourage our community members or to just be alongside them as they're making decisions for themselves is really to make sure that we are strengthening the relationship that we have with them, which is where kinship comes in. And unfortunately, our slide on kinship was missed. So I would have provided more of a piece around that. Let me double check. So yes, for AICAF, kinship is an intentional act to honor the sacredness of relationships, including acknowledging, uplifting, and celebrating the shared responsibilities and interconnectedness of these connections. So how do we honor our relationships so that they support each person in being the relative and ancestor they are meant to be? And how does this relate to all of the work that we are doing here together? Next slide. And so this is one of my favorite resources. It has some of our values on the outside in the little bubbles, including sustainability, interrelatedness, nonlinear nature of time and life, lifeways rooted in culture, balance, respect, and respect for all living things. And then on the turtle's back, you will see some of our Indigenous lifeways, including traditional medicine, natural diet, connection to nature, community, tradition, daily physical activity, and rest. That rest part is really important. We often forget that. And then on the turtle's legs, you'll see some of these like newer lifeways that we have, including screenings, vaccinations, safe behaviors, and regular medical care. So we know that our ancestral lifeway addressed the many potential root causes of cancer, and adopting many of these lifeways are intuitively as well as scientifically supported to reduce cancer risk and bolster natural defenses at all stages along the cancer continuum. The reductionist approach, which really just focuses on maybe fixing the body, undermines Indigenous wisdom. So we really take a look at the interconnectedness of the whole rather than just focusing on one aspect of the person, as knowing that that is true medicine. And we really believe that our interconnectedness is in our relationships. So I'm going to talk a little bit about a few different types of care and how AICAF brings those into the work that we do. So one of these being trauma-informed care. So these guiding principles are something that we take a look at, including safety, choice, collaboration, empowerment, and trustworthiness. And so one of the reasons why we want to discuss that is because we know that many of our relatives have a whole list of challenges and maybe adverse childhood experiences, and want to acknowledge the many situations that our relatives have gone through, not just in their childhood, but also generationally, historically, intergenerationally, and so on. We also want to acknowledge that cancer is an experience that can be traumatizing, which is one of the reasons why it's important to look at the experience of cancer through this trauma-informed care lens. Even preventative screenings, for instance, can come with a potential risk of additional trauma. And this trauma can remove a person from their bodies, which might make it more difficult for them to get in connection with what their body really needs for their treatment. And one thing we like to discuss is how normalizing screenings takes time. And I know that eventually Lindsay's going to talk about our policy and protocols and how it relates to kind of normalizing cancer screenings more. Next slide. So this is a great graph developed by some amazing researchers who are taking a look at Indigenous primary healthcare service delivery models. And so for them, what they found is that they center culture, which is something that we do here at AICAF as well. They also have these different values, including culturally appropriate and skilled workforce, accessible healthcare services, flexible approach to care, community participation, self-determination and empowerment, continuous quality improvement, and holistic healthcare. Next slide. I'm gonna skip these ones just in the interest of time, because I know we know many of these. I'll skip this one as well. And so kind of going back to those different values, as I had mentioned, choosing a screening or going through treatment can really be traumatizing. And sometimes choosing a screening might be a choice, or might be looked at as a choice for some people to choose an experience of trauma, because you just don't know what you're going to get with those results. And so that might be a reason, for instance, that some people choose not to get screened, because they don't want to have to take on that additional labor of the trauma, of the hurt, of the pain, of the indecision and confusion and everything else that goes with it. So here I have a quote from the book, Decolonizing Trauma Work, I believe. Applying a diagnosis all too often pathologizes the person rather than the process that they experience, which brought about the injuries. Furthermore, diagnoses complicate identity development. Given these issues and the fact that most of the imbalance and disharmony experienced by Indigenous people is a result of external colonial focus, it is important to reframe current realities in a way that support healing and wellness. So kind of, again, just going back to the fact that it might be that choosing a screening is the choice to experience trauma, and that there are ways that people might kind of identify with complicated pieces of the story of getting screening, and that we really need to make sure that we are uplifting the person that they want to be in their choice for their treatment, for their screening. Next slide. So as I mentioned, we really try to center relationships and kinship. We know that the foundation of our lives is our deep relationships with one another, with the earth, as well as the animal and plant nations and our ancestors. So one of the reasons why we had you all answer the question, who do you dedicate your work to, is because we know that some of the relatives we bring into the room with us are our ancestors. And so that keeps us going in a lot of ways for doing the work that we do. Building relationships is more than just building rapport. It is deepening relationships for collective collaboration. So really making sure that you're collaborating with the patient, with the relative, the community member themselves. So for us, kinship really kind of takes a few different overarching maybe paradigms, including reciprocity, respect, self-determination, freedom, and or sovereignty. And then underneath each of those spaces, you'll see I kind of listed the different trauma-informed care principles, as well as the Indigenous primary healthcare service delivery values or examples. Next slide. So in our kinship with patients and survivors, a huge question that we ask is, what is the health story or stories that they are sharing? AICAF is really big on collecting survivor stories, which are really sacred to be given the opportunity both to hear as well as to be a part of making sure that others are hearing. We know oral storytelling is a traditional ancestral practice, and that's part of the reason why it's important to make sure that we're doing it, because we know that it's a part of our healing, it's a part of our journey. So in these stories, a few things that might be interesting to kind of look for, maybe as they're telling their story about their health, is what do they value? Because those might be entry points into conversing about why or why not they are getting screened or choosing certain types of care, that kind of thing. Particularly within that, opportunities for connection might include their connection to their tribal nation, their family, loved ones, their traditional medicine and healing practices, as well as their traditional and ancestral life ways. Again, we're trying to figure this all out so that we can answer the question of how do we support the patient, the relative, the community member to be leaders and make decisions on their health that best reflect the person, relative, ancestor they are and want to be. So I'm going to actually go back, and I'm just going to have Lindsay now kind of maybe mention a few things briefly as a nurse, kind of how you brought this into your own practice.
Yeah, so as mentioned, as Misha just mentioned, I am a nurse, and I actually worked in the Bad River tribal community for a number of years. And when I originally started in Bad River, you know, I didn't have a lot of background. And so it took time, and it took time for me personally to learn about the community. And so I would suggest, you know, if you're working in communities, do your research, learn more about the community, be present in the community, take time. So out of your 9 to 5s, actually go to a powwow, actually go to a round dance, you know, be present, be a part of the community, get to know them, get to know what their needs are. Also being sure that, you know, when you are sitting down with patients, you're not sitting down and just saying right away, what do you do for a living? You know, that's not how Indigenous people always identify as by their job. And so really having a conversation, like Misha said, hearing about their story, listening to their story, and finding those pathways to have more conversation. You know, even offering, understanding that, you know, families are very important in Native communities, offering, say, hey, would you like your family member to be in here? You know, greeting their family member, you know, being open-minded. Because it's very exhausting for patients to have to explain themselves, you know, explain historical traumas or traumas in general. And so really just making sure that you're being present and doing some of that back work. So those are a couple of things that I just wanted to leave with you all in my experience.
Thank you. So I'm going to talk a little bit about the cancer survivorship programming that we have here and how we build relationships with our relatives. Next slide. So overall, a few big things that we have going on here is we have our Cancer Survivors Leadership Advisory Council, which kind of just closed its first chapter for now. We are in the evaluation period, which we're really excited about. We have our Cancer Support Circle that is run bi-monthly. We do one-on-one check-ins. We also have a huge campaign during June, as many places do, called Celebrate Indigenous Life, which is our national campaign to honor and celebrate our Native cancer survivors. We do many, many surveys to figure out what our relatives need. We also have survivor and caregiver resources, including interviews, print and digital resources, as well as policies and protocols, particularly for health systems. Next slide. So for those who might be interested, there are some themes that emerge from our Cancer Survivors Leadership Advisory Council meetings, including listening, non-judgment, and acceptance as some of the main values. I think those are really important to bring into the space because this is what our relatives who have that cancer diagnosis are saying that they need from other relatives. They need to be listened to. They need to know that this person is coming from a place of non-judgment and that they're going to be accepted. Another big thing that I've heard mentioned is knowing that every cancer survivor cancer patient has a different treatment journey. That is really important to acknowledge because that's where we can really put some of these values into place. Another thing that we saw was that more support was needed for the survivor themselves. Of course, we know that, but they also really mentioned that there's more support needed for families and loved ones, as well as the healthcare team. Some of the projects, some of our projects here at AICAF definitely included our advisory council, including our cancer plan, as well as the Celebrate Indigenous Life campaign this year. Next slide. As I mentioned, we have our AICAF Cancer Support Circle. I'm just going to talk really briefly about it. We meet twice a month on Thursdays at 6 p.m. Central. We'll actually be meeting tomorrow evening, and we'll be joined by one of the advisory council members, Carol Hernandez, who's going to be talking about building self-worth through creativity. There will be an ornament making project, but if you haven't signed up yet, you might not get those resources, or you probably wouldn't get those resources in time. But the circle is open to Native cancer survivors, patients, and caregivers. Next slide. And that is our current flyer. So as I mentioned, we do one-on-one check-ins. So we have our Building Kinship with AICAF Survivor, or Building Kinship with AICAF interview survey. So that kind of just goes through what resources are you looking for, and really just allows us to kind of review our survivorship opportunities and programs with a relative, because we know that oftentimes it's really kind of strange just to see this big organization entity and not really know kind of like what they do. And so we want to make sure that our relatives feel like they can come to us and figure out what's going on at AICAF. And so this is how we do it. Next slide. And so this is a little bit about our Celebrate Indigenous Life campaign. You will see on all of our resources, it has the purple and lavender theme. So this is a huge banner that we have shared with clinics across the country. And so it's split in half right now, but usually it would just be like one long banner that they can put in their entrances, lobbies, areas. Next slide. So we do a number of different activities throughout the month, including many different webinars. So this is some of the stuff that we did last year. I wish I would have updated it with the stuff that we did this year. But for instance, last year we started with a virtual prayer event, and then we ended with a virtual walk run in which we also send prayers out for our relatives. We have a number of webinars that are usually based on either what the cancer survivors' relatives are saying or what our advisory council members wanted to share. For instance, that's what we did this year. Next slide. And that is our team on our prayer walk. You can keep going. And then we have a number of resources here at AICAF, as I mentioned. And so this is one of my favorites. This is our Indigenous Food for Your Gut Health. This was created for colorectal cancer specifically, but of course applies for many, many different things. And so this includes indigenous foods to, I believe, maybe North and South America, and I believe all of them but one, unfortunately, but fortunately is native to these areas. And one thing I want to point out is these resources usually include a tribal word for maybe a type of food, or for the word relative, or just for some type of word. So we have that representation. Next slide. This is our most requested resource. This is our family history tree. And so, as I mentioned before, our advisory council mentioned that they want more resources for their families and their loved ones. This is something that AICAF already had published, but in collaboration or in partnership with one of the clinics, as well as just hearing from our advisory council, we have created kind of the backside to discuss like why it is so important to use this resource. Next slide. And then this is probably going to be my last resource for now. This is our Advancing Care document, which includes information on kind of having a living will and how we can kind of incorporate some of our Indigenous values practices into this document.
Yeah, so Misha mentioned about our survivorship policy and protocol. And so we can, we can go through this pretty quickly in the interest of time. So policies and protocols are extremely important to have in healthcare practice. They're guidebooks to support cancer prevention and survivor support. So it's really important to be thinking about this. So what's the difference? So policy is not an immediate, it grows over time. Really thinking about that policies really are a helpful in decision making. It's a type of document that lays out organizational standards and practices. So, for instance, if your organization follows USPSTF guidelines. A protocol is a defined set of procedures. How are you going to do this? What are the steps? So keep in mind when we're talking about a policy and protocol. So AICAF has been developing policies and protocols for lung cancer, breast cancer, cervical cancer, and colorectal cancer, in addition to survivorship. And so I'm going to highlight our survivorship policy and protocol. We started out with our survivorship protocol, really defining what a survivor is, previously to what Misha said is AICAF's definition of a survivor. And so this is an important baseline when you're thinking about developing your own. What does that look like? The next part of our protocol goes into communication cues. What are some of the things that you should be, talking to a survivor about? How do you provoke those questions? What are some ways that you can get them to share their story so you can learn a little bit more? Understanding communication is key to any relationship between people. Be sure to have these conversations with your team ahead of time to understand the best route and form of communication to build these relationships with your survivors. In the following sections, we really talk about the nitty-gritty pieces, data surveillance. The screening section is really dives into knowing your community, knowing what your survivor outlook looks like. Discussions on rescreening. So what does that look like? How do you rescreen a patient? What is that? What is that protocol there? Because a lot of what our advisory council talked about is, once I'm done with my treatments, I don't know if I have to go back and get screened. So this is important things we should be talking about with our survivors. Do they have to get screened every 5 years? Do they have to get screened every other year for breast, cancer? What is that rescreen process? What are those outreach efforts that you're doing with your patients? How are you documenting this in your EHR? Are you assessing structural barriers? What are the things that our survivors still need in place to receive the care that they deserve? Following that is assessment and management. And our protocol really focuses on vetting local resources. That was another thing that was informed by our advisory council, is really making sure that you are going ahead and vetting local resources so your survivors know that these are trusted organizations to use. And we're actually coming out with a resource to help you all with that. So stay tuned to that. So care coordination, just talking about the importance of bridging care across all aspects of the survivor care team. So from their cancer doctor to their primary doctor, what does that look like? And then talking about post-treatment, what does post-treatment look like? Discussions with survivors that reoccurrence can happen, and so understanding that that might be a trauma piece, and understanding how do we have those conversations with that survivor and being honest with them. Much of the protocol, like I said, was informed by our advisory council, but it's important to talk to your survivors. And last slide, and then we can go into the breakouts. We're a little over, sorry about that. So how do you start? You might be asking yourself, what do we do? This is a lot. How do we even go about this? My recommendation, just start having conversations. Jot down what you currently do for survivors, have some brainstorming meetings, group the topics into the cancer continuum from prevention to hospice. What does this look like? What are you doing? What are the gaps? Ask around. Do any of your local partners have a successful survivorship policy and protocol that they're using and that it's in place? Meet with your survivors. Actually have an advisory council. Find out what survivors, how they can inform and improve the health and wellness for other survivors in your community. And maybe create a survivor leadership council. What other ways can you include survivors in your work? So think about that. I will say this might seem overwhelming, but the best thing to do is just start. Policies and protocols can develop over time and then be improved with time. It doesn't have to be perfect right away, but it has to show that you're putting that effort out there. So Misha and I thank you so much for listening to us today. At the end of the slides, Tina, there is our contact information, and I can put that in the chat as well.
Well, thank you both, Misha, Lindsay, amazing presentation. And we will share the slides with everybody later and make sure that we share your contact information as well. Because I saw the chat and I know there are many people interested in the information you were sharing and the resources as well. So what I would love for us to do is if we are able to go into breakout rooms for a little bit, we'll spend about 10 minutes there just talking about what we heard, see if there's more things we want to discuss. And then we'll just come back into the main room and do a closing for a few minutes. If we have time, we'll answer some questions. And then we will have everybody out by 11:30 this morning. So I believe we are set and ready to roll. We just broke people out in random breakout sessions. There'll be a facilitator in each room. And for those that are nervous about breakouts, this is not high pressure. So this is just a fun way to meet some new people and listen to some conversation. So All right, wonderful. Well, you all get an A+ for sticking with us till the end. So I really appreciate your engagement and being a part of the webinar today. I know we have a few more people jumping back in, so I'll just let everybody get back in. So thank you, everybody, for sharing your time with us today. We really appreciate it. Hopefully you found the speakers just absolutely fantastic information. It was kind of what we talked about in our breakout session of just, the more we can learn and share is so appreciated. So thank you to all of our speakers. We really can't thank you enough for sharing your not only just your knowledge and but just some of the things that we walked away with and just feeling like how we as professionals know more and how we can support the work was really meaningful to us. So I just wanted to see if there were any thoughts from anybody that they wanted to share in the last few minutes, if we have any questions or if we had anything. Otherwise, I will just close us out for the day.
I could just say that it was great to hear land acknowledgements. That was really huge for me. So I feel like it's all going in the right direction. It felt really good to hear. It felt really good to see. I see people that look like me. I think that's really cool. This conference is really great. I was just telling our facilitator that I'd like our community health workers here in Milwaukee to watch the video because I think it's a really great place to begin. So Chimegwech.
Oh, thank you so much. I appreciate that. Thank you. And thank you for being here. And if there's anything else, as we've mentioned, one thing is please stay connected. We love hearing from everyone and we want to always keep doing more. I do see a hand raised. Hold on. Regina, let's see. I'm finally, after 2 years, mastering Zoom. So Regina.
Yeah, I just wanted to share a little bit about a conversation that we had in our very small group. And it was fascinating because I was speaking with someone who works with Indigenous populations and talking about how survivors do see themselves as warriors and having been brave. And I asked a little bit about that because I know in some circles, there's talk about trying to get away from the battle and warrior type of phrasing, because then when people die, it's as though they didn't try hard enough. And her comment just really touched me because she said, that survivors don't necessarily mean you remain here on Earth. We have other callings. You carried on the battle somewhere else. And I just found that really incredibly touching and beautiful. And I just wanted to say thank you for sharing that with me today to my compatriot in my group.
Thank you, Regina. Thank you. And I think that's maybe a very beautiful way to close this. So thank you for sharing that with us. And if you found today exciting and interesting, and I would say what's fascinating is this today, and some of the speakers have acknowledged the importance of stories and the importance of our ancestors and the importance of what we hear, and not only how we tell the story, but those that hear it and what it means to us and how do we carry it forward. I just want to mention that has been the thought and the inspiration for our Fall Wisconsin Cancer Summit. So we are hosting an in-person summit on, we'll have a reception the evening of the 19th, and then the full conference will be on the 20th. So it's going to be in Madison at the Edgewater Hotel. Please look for more information on it, but the theme is the power of story. So we are really excited that we're going to be able to, we call it connect, transform, learn, heal, but just we know that stories are so critical to who we are as people, but also how we do our work in public health. So we're going to bring those all together for a really powerful and in person, or just saying it, I'm very optimistic that we'll continue to remain and we'll be able to gather together again after several years. So I just wanted to give everybody that. And then the second piece is that I want anybody who is a part of our members, we are going to be doing a survey. You will be receiving it shortly. And this is just the way, as I know, I think it was Misha and Lindsay spoke about the importance of surveys and knowing about what individuals feel and how they can help support. Well, we feel the same way. So we are doing a survey of our members, and we really would love your feedback on how we are doing on our programming and an overall program. So I want to thank you all for joining us today. And I am going to, I think you will either receive a survey or there will be one shortly after you close out of this webinar. So please also provide information on how we did today. And I wish you all the very best and hope to see all of you soon. Thank you.